So we're really making sure that we are getting as much information and as many experts in this 8-week, or I guess 9-week period as we possibly can. Okay, so I want to start off our event as we usually do, going in a little different of a route. So what is something in your professional life you are excited about and why? I'm not saying it has to be about SMBP, but I would love, of course, if you all were just as excited about it as I am. But what is something in your professional life you're excited about? Don't be shy. You can come off mute or you can chat in, either or. I'm going to call on my co-facilitator. And Erin, what's on your docket about something you're excited about?
Yeah, so I think right now, something that in my professional life I'm excited about is getting lots more clinics. I got a new clinic on board for SMBP in Alaska. So just increasing that recruitment and getting clinics really excited about it makes me excited.
That's awesome. I love it. New recruits are always fun. Yeah. I decided to take a wild hair. One of the things I have to do for a lot of the work that I do is writing. And it's been a good amount of time since I've taken a college level writing class. So I decided to take a creative writing class that will hopefully help me get over some of those writer's block hurdles that I get. So we'll see how that goes. Okay, so we have Deb chatted in, one of my colleagues at Mountain Pacific, starting work on social determinant of health presentations using technology in rural communities. Yeah, that sounds awesome. We have our resident expert technology person on the line. So if you've got technology questions, Deb is a fantastic resource over here at Mountain Pacific. Chris says, my team, they are the best, being able to create programs together to support our community and physicians. Yes, absolutely. And I can for sure attest to the work that Chris and her team are doing, incredibly invested in their patients and leveraging their relationships to, get the work done. It's fantastic. Jamie chatted in, learning more about the CCM case management certification and hoping to start training and becoming certified sometime in the future. That's awesome. Yeah, so chronic care management, case management cert. Always good to advance those different areas. Some of us, it's been a long time since we've done any kind of formal training, or maybe training that is directly related to care and how it's changing right now. We're doing things quite differently than we kind of did in the past. And we've got Navya from the Hawaii Primary Care Association. Really excited to have her on the line, learning more about health systems transformation. Well, in my complete and utter bias opinion, you came to the right group of innovators right now, right here. And Patty is on a health equity kick right now. If you have not registered for the Learning and Action Network that we've got going, I believe next week, Patty, correct me if I'm wrong, maybe you can do a shameful plug about what the date, time, and your content is going to be for that particular event. We may have you double muted, but perhaps you could just throw in that registration link into the chat and we can get folks maybe that haven't registered for that.
Will do.
All right. So,
Sorry,
there you are.
Yep.
Great. Well, awesome. It feels like a lot of the things that you all are excited about actually quite align with the work that we're doing in SMBP in one form or another. We're all about innovation and finding alternative ways to improve the health of our patients. So some familiar faces on the line today, and then we've got some new guest speakers. So I'm Kristen Schuster. I guess I'm your kind of MC for these events. Maybe I'll get into a career of wedding MCing or something like that after this. But I work with Mountain Pacific and a lot of clinics across Montana, Hawaii, and as well as North Dakota. We've got Erin on the line. She is working with clinics in Alaska. And then we have Jessica from the American Heart Association, who is our wealth of knowledge and tools expert for all things SMBP. All right, our ground rules, all of these are pretty familiar, so gonna buzz through them pretty quick. So we're gonna assume positive intent. We're gonna be here in the now. Come prepared to share, that's my big one. You all are working through all of this fantastic work over the past few weeks, so we wanna hear and learn what your experiences are, and then also, what are some of your needs so we can better meet those in the final session or perhaps in sessions to come. Decrease distractions and respect time, and then everyone teaches, everyone learns. And I will say we have Dr. Humphrey, who was our guest speaker at the last session, who's on the line, welcome. And he says one of the things that he's most excited about is having been working his section on remote monitoring interoperability. And we're looking at improving the analytics to improve SMBP. Well, that sounds great. And I will extend the invite to our final session because we are going to be talking a bit more about data collection and what we do with that. Okay, so this is a collaboration for our regional partners. So this includes national as well as state organizations from Montana, Hawaii, Alaska, and Wyoming. We're thrilled to have all of this group together to be able to pull experts to create meaningful content for all of you. In these slides, we will have the embedded link to our first session and our second session recording. I will also send out the recording of today's session towards the end of the week. And I did want to highlight that we did push the final session out a week, and that is going to be on July 13th at the same time. If you have any questions about that populating on your calendar, or if you're having any issues, please feel free to reach out to myself or Patty Kasednar, who has been working on kind of the back end tech side of things for any issues that you run into. Because of the holiday and there's a good amount of lift around the patient engagement work, we really wanted to make sure that you all have enough time to do our work. So a quick overview of our agenda today. And we are going to get into our call to action. So how have things been going? So what processes did you use to identify and recruit patients? So if memory serves, a good amount of you are going to utilize your EHR, some different quality measures. Over the last 2 weeks, did you find any that really stuck? What are you utilizing to identify and then recruit patients for SMBP? And I see Ryan on the line from MSMP. I would love to call on you and see what your method is for identifying patients, especially since you're pulling patients from multiple providers panels. So feel free to come off of mute or to chat in your response. But I know you all have some good ideas around what you're going to utilize to recruit. I work on a lot of different platforms. One of the things I'm not as happy about with Zoom is I can't see when people are typing. In Adobe Connect, I like it because it'll say so-and-so is typing. So I know you all are awake, but I'll keep waiting and hopefully y'all are chatting stuff in. But again, you can come off of mute. All right. Ryan said we used our EMR record to identify patients who had been diagnosed with hypertension, and then we went to the individual doctor and had them specifically point out patients they thought would be receptive or could be helped from the program. I love it. So marrying data, like kind of the first step of identifying patients, with your care team members' perspective, right? The data can say one thing, but if the patient either isn't open to it or the provider doesn't think maybe they would be willing, or maybe they don't have the resources, may not be the best fit. So especially when we're starting small in these pilot projects, in order to, kind of work out the kinks, it's good to find patients that are open so you can figure out kind of your workflow processes. Love that. Patty, you work with a lot of clinics. What are you seeing from clinics utilizing different types of data or identification for patients?
Well, the easy low-hanging fruit is to run your CMS 165. So all of your patients with hypertension who aren't in control. But one of the things that we're also doing really to focus on health equity as well is of those identify the ones who may be at higher risk from a social determinants of health point of view. So there's a lot of different ways of looking at the data. Like you can start your patient panel with CMS 165. And you can also do it with your diabetic patients. So look at your CMS 122. Are there any diabetic patients that are at risk that you might want to pull in? So there's a lot of different ways to start, and then you can cross-section the information to get it down to a reasonable size for you to start your program, if that makes sense.
Absolutely. Yeah, those cross-cutting measures, right? Those ones that kind of meet the needs of multiple either programs or multiple quality metrics to really get the most kind of bang for your buck out of improving care for them. Love that. Okay, have you started to reach out to patients yet? So what are you experiencing? Have you talked to anybody? Have you seen any successes in your outreach attempts? Have you seen any challenges? What have you experienced in the last, I guess, what are we at, 6 weeks? 4 weeks?
Come on, you guys, come off of mute. Don't be shy.
I know we've got a pretty small group here. There's only 18 of us on the line, and none of us are very judgy. And going back to our ABCs, everyone teaches, everyone learns. So there is no win that is too small in this world. So maybe one patient, that's great.
And then if you haven't started patient outreach yet, maybe sharing where you are with that process of developing that process to outreach to patients.
Or even providers. Like, what have you already started talking to your providers about? Have you started selling the SMBP program to them? It'd be interesting to know. And Hope, I don't want to call you out, but I know you're working with a lot of different organizations, a lot of different clinics. Have you started talking to them at all?
No, what I'm planning on developing is kind of a startup tool for our CIN participants to start deploying that within their program, and to kind of answer how we would identify them. Because we are a clinically integrated network, we are going to be able to see who those ones are outside the parameters and make recommendations for patient selection.
Great. Well, Anna, so CIN is clinically integrated network.
Yes.
So you just gave me another idea. Some ways that I have clinics, some of the clinics I'm working with are identifying patients is from their payer partners. So a lot of the payer partners have information that if you reach out to them and say, which one should we keep an eye on? They already are looking at that data. And some payer partners actually are putting SMBP programs in place. So working with them helps you all do that communication a little better.
So Patricia, do you know what health plans are currently deploying them? Are there any in Montana? Because I'm not aware here.
Well, I know, Erin, you ran into it in Alaska, right? With Premera?
Correct. It's Premera, Blue Cross Blue Shield of Texas and Illinois.
Okay. I'm not
And they're
it's
providing
through a
SMBP?
program. It's through a program called Livongo. And they're offering a blood pressure cuff for 30 days. I haven't gotten more information, so I apologize, and maybe I can report out on it if I'm able to get in contact with someone from the Illinois or the Texas office next time.
I don't know. So Hope, just to answer your question, I'm not sure who in Montana is, but I know if you reach out to Medicaid and a Blue Cross Blue Shield here in Montana, they are collecting information, especially through the GAP report. If any of your folks are doing the GAP report for Blue Cross Blue Shield, they have a good idea of which patients they would like to see on a self-measured blood pressure program.
Yeah, absolutely. But I guess the question was though, the insurances that are already deploying self-management. And I was not aware of any insurances within the state that have already deployed their own program like Livongo, which I am also familiar with peripherally.
Okay. Yeah, I'm not sure in Montana either, Hope.
Okay.
Yeah, I haven't had a lot of experience with clinics in Montana saying our payers here are doing any like direct care in the same fashion that Alaska is. And then in Hawaii, HMSA does some direct care as well, although I don't believe they've tapped into the SMBP world as much as the care management and behavioral health integration world. But definitely partnering with the payers as much as you can is definitely a good starting point, especially if you want to look at, you know, getting into maybe some different patient populations, you know, Medicaids, commercial insurances, Medicare Part Bs, you know, aligning with the different programs that you're working on, whether that be, you know, a value-based contract, maybe it's an ACO or, you know, some other incentive program that you're working around, you know, looking at those patients as potential starting points to be able to, you know, look at improving metrics that maybe also have some additional revenue associated with them. So with that, I'm going to hand it over to Kendall to introduce our guest speaker. Take it away, Kendall.
Okay, great. So actually we have a couple of folks from the Hawaii Primary Care Association today. We have Marichi Barbosa, she's a program specialist, and then our main speaker, Navia Karkata, is a senior program specialist. So Navia has actually been with the HPCA since 2018. She's currently working on Hawaii Health Center Control Network grant, and which is primarily a health information technology based grant. And additionally, she also works on patient-centered medical home quality improvement initiatives, hypertension, and diabetes through the 1815 grant. So I'm gonna transition over to Navia. So Navia, go ahead. Thank you.
Thank you, Kendall, for the warm introduction. Hello, everyone. My name is Navia Karkata. I'm a senior program specialist at the Hawaii Primary Care Association. My colleague Brian Wan was also supposed to be here, but he's on vacation right now. So I will be going through the presentation. I just want to give you all just a heads up that I have a mean cold right now. So if I pause or if I go off camera, please excuse me. I probably am coughing. Sorry about that. So without further ado, we would like to go over our patient engagement and patient reported outcomes related work with SMBPM that our FQHCs have worked on for some time now. Next slide, please. We just want to briefly go over our objectives for this presentation. We provide a brief overview of what HPCA is and what we do, history of the SMBPM work done at the Hawaii FQHCs, some of the staff roles in different the different models of FQHC SMBP programs, identifying patients for SMBPM, and it goes back to some of the discussions that were had earlier, and what an initiation visit for SMBP would look like, and what would be included in a blood pressure education packet, and some patient engagement strategy, and we will finish off with some Q&A. Next slide, please. Just to give you a brief overview of who we are as the Hawaii Primary Care Association and our role, we are a primary care association. Like most of you know, we provide support and technical assistance to our health centers and the communities that they serve in Hawaii. And our three major goals that we are currently working on are to increase access to comprehensive primary care, accelerate value-based care delivery, and foster a health center workforce to address current and emerging needs in our ever-changing communities. Next slide, please. So we have a total of 14 a federally qualified health center and one a federally qualified health center lookalike. We have one health center on each island, as you can see in our map right here. Next slide, please. So moving on to the history of SMBPM, our SMBPM journey with FQHCs started with the 1422 grant, the CDC 1422 grant, which was active from 2015 through 2018, and we worked with DOH on that project. And for this particular grant, we focused on health systems improvement for the vulnerable populations. And when I say health systems improvement, we were looking at quality improvement activities like identifying patients with undiagnosed hypertension, prediabetes and diabetes, and including any sort of HIT improvements as well. And we worked on continuous QI improvement activities to identify strengths and weaknesses within the health centers, expanding care teams to include multidisciplinary team members, and then ensuring that the staff at the health centers are also working on top of their licenses, and including community linkages like reinforcing behavior in the community level as well. So it's not just us saying to the patients do X, Y, and Z, but when you go into 7-Eleven, you see all the junk food. But the work that we were able to do with the Public Health Institute and DOH here was having these stickers in 7-Eleven that shows that this is healthy food, and having this signage so it's easier for the community members to see what is healthy and what should be had and stuff like that. And also we worked with some of the health centers in helping them implement a bike path around the health center. So we had around 9 FQHCs that implemented SMBPM through the 1422 grant. And like I mentioned earlier, we included a multidisciplinary team within the different health centers and also worked on community linkages. So currently we are working on the 1815 grant, and this has been helping to sustain the SMBPM activity at the health center. We have included one additional health center that has come on board for 1815 and is implementing SMBPM, and the 1815 funding has been helping to sustain the other health centers within our FQHC networks to continue providing SMBPM services. In addition to that, we are kind of tying our work with 1815 with our work with the Hawaii Health Center Control Network grant, which, like Kendall mentioned, is our HIT grant to work on remote patient monitoring as it relates to SMBPM. And we're looking at more of the Bluetooth technology and how to make data integration for remote patient monitoring seamless for the care team members. So with COVID and sustainability, our health centers, like most of the health centers and health systems around the country during COVID, had to pivot to telehealth. And the same thing happened with SMBPM, where our health centers shifted to doing the virtual SMBPM program. So that's where the shift happened, and we had to integrate quickly to telehealth to provide initial and follow-up visits. And with COVID, the other challenge that was that came to our attention was lack of blood pressure monitors. So we quickly increased our partnership and connected with AHA and NAC to ensure that our health centers have enough blood pressure monitors through the pandemic. And we are also currently working with some health plans in trying to understand what the process is for health centers to get blood pressure monitors from the health plans itself, instead of being reliant on grants and other programs to get access to blood pressure monitors for their patients. Next slide, please. So with regards to SMBPM implementations and increasing patient engagement, having a team-based care is key, so that the patient has as much exposure and touch points with different team members within their care team. So obviously we'll have the provider who would be doing the referral, talking to the patient. We'll have, depending on the type of the model of SMBPM that's being implemented at the health center. We might have a pharmacist involved. We might have health coaches and community health workers involved, care coordinators, and also most of our models with the providers include a nutritionist as well. So having these multiple touch points with the patients are very important in increasing engagement for our patients in the program and keeping them, engaged and being there in the program and not just slacking off after like the first week or so. Next slide, please. So I just wanted to go over some of the SMBPM models that have been implemented at our health center. So we have a pharmacy-driven model where our pharmacists would be doing medication management, medication intensification, titration, all of that in conjunction with the primary care provider, but the main SMBPM program is run by the pharmacy team. And then with the clinical care team type of model, we have the provider in the center of the care team with the care coordinators helping the providers with tracking the patients, getting information on their blood pressure readings, providing additional support. And then finally, we have the outreach-driven model where CHWs go out in the communities, and any patient that may not have been eligible for care coordination, they take over those patients and implement an outreach-driven SMBPM model to include any additional patients that might be that might benefit from having participating in the program. Next slide, please. We just wanted to give you a brief snapshot of our population that the health centers serve. So like you can see, around 85% of the population served by the health centers are at or below 200% below 200% of poverty line, and then 64% are at or below 100% of poverty line, and almost 50% of our patients are on Medicaid or CHIP. And although the slide shows that we have around 11% of our patients that prefer a language other than English, it depends on the community health center we are looking at and the community that they're living in. So we have a few health centers here in the Kalihi area where they have around 60% of their patients that are served in a language other than English. So if we look at the racial breakdown, majority of our patients served at the health centers are either Native Hawaiian, other Pacific Islanders, or Asians. Next slide, please. I just wanted to, with the previous slide, I just wanted to make the point that because the group of patients that we serve are so vulnerable, we do need to have that multidisciplinary, diverse team, so we can have these multiple touch points with these patients at different levels. Moving on to the staff roles, there are three major categories that we identified for staff roles to improve engagement. One is identification, the other one is outreach and follow-up. So with regards to identification, you need to know who in your team is identifying your patients that are eligible for SMBPM and who's running the algorithm, how often are they running the algorithms to identify the patient. And then for outreach, who is calling the patients, who is, once they receive the referral, how are they talking to the patients, what type of outreach is being done. And then with the follow-up and initiation visit, who exactly is doing the follow-up and what is being covered in the follow-up visit. So our health centers, majority of our health centers are patient-centered medical home recognized. So our health centers have been practicing as a PCMH or a health center for some time now. So team-based care has become, is ingrained and is a part of the practice. However, even in a team-based care environment, what is important is to make sure that your tasks are divided and has been assigned to each person in the team, so everyone is on the same page and know their task. And it's not like, oh, I thought she or he was going to do identification. I didn't run the algorithm. So everyone's on the same page and we're working as a team, as a well-oiled machine. And this is going to help in successful implementation, successful engagement, and eventually long-term sustainability of the program as well. Next slide, please. So with identifying patients, this kind of addresses some of the discussion questions you had earlier. And I think there was a question that popped up in the chat box as well around identifying patients. So some of the things that we've advised our health centers and they've taken into consideration in developing the algorithm are using risk stratification processes. So how many of your patients have diabetes, hypertension, and any other chronic conditions, plus their SDOH scores. If they have like a SDOH score of 5 and over or 3 and over, taking all of that into consideration and putting your patients into different categories, and based on that, doing outreach and involving them in the SMBPM program. The other thing, other way of identifying patients, of course, is identifying anyone with undiagnosed hypertension, but may have elevated blood pressure readings for the past 2 visits, but they have no hypertension diagnosis. Also, there might be patients, there was in the discussion earlier, they talked about how getting the input from the care team is key, like for patients that might be coming in and they are, every time they come in, you see that their blood pressure readings are off the roof, but then it may not, like everything else seems fine. So if the care team or the provider is suspecting white coat syndrome, that's another way of, choosing patients to be a part of your SMBPM program. The last category that I would like to shed some light on is hypertensive patients with barriers to care, such as homebound patients or patients that won't be able to come to the health center for whatever reason, be it transportation or any other sort of SDOH factors. And identifying those patients, it could be a part of your risk stratification as well, but identifying these patients and thinking of how and who in your team again will be engaging with the patient. Would a community outreach worker go and do the follow-up visits, or would it be your care coordinator? So just having that discussion and plan around reaching out to patients who have barriers to accessing care. Next slide, please. So coming to the initiation or the first visit with the patient for SMBPM, the first step that you could potentially take is assess the patient's readiness and confidence in participating in a program that involves self-management. You could use motivational interviewing techniques of using the readiness and the confidence scale or ruler, and then see where the patient is at in that confidence scale and assess if they would be successful in this program and what might the care team have to do to ensure the patient's success in the program. Also, this is a good time to assess the patient's ambivalence if needed. If the patient is like, I don't think I have a problem, you could talk through what the patient is thinking right now, where they're at, and how can you improve the patient's self-efficacy, or at least give them tips on how can they work on improving their self-management skills during the duration of the time that they're in this program. And then the next step is assess any barriers and facilitators to patient success. If you haven't done an SDOH screening at this point yet, this would be a good opportunity to do an SDOH screening, assess what might be some of the barriers to patient success. It could be that the patient has issues getting enough food. So food insecurity might be a problem. How can you address that? Can you refer the patient out to like a food pantry, or give them veggie RX or anything that could help patient in bridging the gap to ensure that they are successful in any way possible. The other thing to take into consideration, especially for us here in Hawaii, with so many cultures and racial and ethnic groups represented, is tailor patient education and on hypertension and SMBPM. provide culturally appropriate examples, use like, we cannot like, for food as well, like think of ways that you can use some of the local foods instead of giving a very broad based example that does not resonate with the patient. And additionally, the important thing here would be to have a dialogue with the patients while you do the education piece rather than a monologue. So when you're having a dialogue, you understand where the patient is coming from, and it helps you better tailor the session for the patient. And then the next step would be to set SMART goals, set achievable goals with the patient. It could be small stepping stones, but even if it's a small goal of, okay, I'm going to walk for 30 minutes for 3 days a week, that is a small goal that you can set with the patient and make the patient have some sort of accountability towards the goals that they have set. And then train the patients to use the blood pressure monitors and use of the blood pressure logs. Use the teach back method, and then do ask with the patients, provide a lot of visual aids, and any other sort of information that you can provide to help patients once they go back into their homes to do their own self-management. And finally, provide any adherence tips to the patient, maybe things like asking the patient to set an alarm each day to check their blood pressure in the morning and at night, and or sending text messages to the patient reminding them of what they to take their check their blood pressure or take their medications. Next slide, please. So finally, with the blood pressure education packet, this would go with your first initiation visit. Some of the things that you could include here is a patient contract. If you have a BP loaner program for your SMBPM, this is where you can include your SMBP loaner program contract that would have their when did you loan the blood pressure monitor to the patient, when is it due back, and all of that. So the patient knows that that blood pressure monitor is not exactly for them, but they need to return it. And then maybe a flyer with information on hypertension, and another flyer with how to accurately check your blood pressure. And Target BP has a lot of great information that is at like a third grade reading level that could be provided to the patients. And a user manual. What we've learned from our experience working with the health center is some of the user manuals that come with the blood pressure monitors have a lot of text, and that's not very useful for our patients. So finding a user manual that has a lot of pictures rather than a lot of text on the manual itself. In addition to that, HPCA, as a part of 1422, they developed some feel-good materials, which are brochures on sodium, calcium, fiber, and eating a rainbow, to talk about how they need to eat fruits and vegetables. So these are some of the things that we also provide the health centers, in addition to some of the other things that I mentioned that the health centers could include in their education packet for their patients. Next slide, please. And then coming finally to our patient engagement strategies, like I mentioned earlier, having a very multidisciplinary group of team members is great. So is integrating your SMBPM program with your existing lifestyle change programs, which could include diabetes prevention program or diabetes self-management education program as well. So we know that majority of our patients here have 2 or more chronic conditions. Mostly it's diabetes and hypertension. So it works very well for our health centers to integrate their DPP and DSMES programs with their SMBPM program as well. Additionally, providing incentives to patients, like providing vouchers to go to the farmer's market, providing food prescriptions, Veggie RX, or gift certificates to redeem at the local farmers market. Increasing access to fitness programs. Some of our health centers have gyms. Some of our health centers do provide hula for health and Zumba and other sort of physical fitness programs. So increasing access to such programs for the patients would improve engagement as well. And the one thing that we learned, and which was challenge for our health centers when they did initially transition to virtual SMBP, is having group sessions. So our patients here really loved having group nutrition counseling sessions, cooking demonstration, and a chance to bring all of your SMBPM cohort together and have a session where they're talking about what each patient is doing, what has been working for one patient. So there's shared learning among the patients, and the patients really valued this pre-COVID. And when our health centers transitioned to virtual SMBPM, that was one thing that the patients missed a lot, coming together as a group and talking to each other, especially the elderly patients. And then finally, leveraging partnership with your local farmers market, local gyms, your YMCAs, AHA. So like I mentioned earlier, we partnered with AHA, and they have a program here called Adopt a Clinic, through which some of our health centers are able to get blood pressure monitors now, so they don't have to like wait on a grant or get some funding from other areas to be able to have sufficient blood pressure monitors. In addition, Million Heart, CDC, and our local public health institute is also a good resource that we've partnered with. Next slide, please. And I just wanted to highlight some of our tailored engagement strategies that our health centers have worked with. One is the bike path, like I mentioned. Our health center on the Big Island, they worked with their local government to have the bike path instituted. So it's right around the corner from the health centers. So it kind of encourages the patients to have these opportunities to, go out and be active. Additionally, you have the Hula for Health and a community garden. They do beach cleanup, and also in the picture in the center, you see them pounding taro as well. So any local activities that your patients could be engaged in, tailor your engagement activity as much as possible so that they are going and doing something that they like to do, rather than instead of just saying, oh, you need to improve your physical activity, but knowing that they probably live in an area where they don't have parks, they don't have sidewalks, it's not very helpful. So again, understanding their barriers to care, and then what can we do as a health center and or a health provider to bridge the gap as much as possible is something to think of, and that would help in engaging the patients even further. Next slide, please. So here we just wanted to show our data and highlight that we don't really have access to robust point-in-time data. We only have access to such data for 7 health centers. So our data source is right now UDS, which is static. And as you can see, we have about 8 health centers that have reached HP 2020 goals, although we cannot directly attribute everything to SMBPM because there are a lot of other programs that are being done at the health center too. The one thing that we would like to point out is that SMBPM does help out in improving outcomes. Additionally, with SMBPM in place, our denominator for the number of patients with hypertension has been increasing because SMBPM has played an important role in also accurately identifying patients with hypertension and eliminating anyone that might have had white coat syndrome, so that we are not simply having patients on our patient list and on medications when it's not needed. So SMBPM has had an important role in patient outcomes. And to just share a story with regards to the engagement strategy and how this has helped, we have had in one of our health centers where they did have a loaner program, one of the patients asked if they can have the blood pressure cuff for life because they didn't want to give it back, is because they wanted to continue to monitor their blood pressure, although they had reached the goal that was set by the provider and the group and the program coordinator. The program has helped improve patient self-efficacy and self-management. And I think that moving forward is going to be very important as we kind of explore more around remote patient monitoring and the patients being, or patients driving what is being done at home with remote patient monitoring. So this has been one of a first step for our health centers in helping improve self-efficacy in self-management of patient-driven outcomes. Next slide, please. And these are some of the considerations that we would have to think about. And this is my last slide. You need to think about where are you getting your data from? How is the data collection? What's the process? Where is the data being housed? Is it like in your portal? Is it in your patient? Is the patient just bringing in physical BP logs? And if not, are you just logging everything in an Excel spreadsheet? Is it in your EMR? So that is an important thing to think about. And what data elements do you need to collect from the patient, and how is it going to be used in the future as well? And think of how you could use technology to simplify data collection, using Bluetooth blood pressure monitors, using patient portal, so that the burden on the care team reduces, because some of our health centers right now with the virtual SMBPM and us not being there yet ready for RPM, we have health centers calling the patients and patients just reading out their numbers, and which is not the best way to do it. But when COVID hit, that was the only thing they could do. So just think of how you can simplify data collection methods. And then finally, sustainability, with the major barrier we have is as the blood pressure cuffs that we're trying to work with the health plans and also with various partnership, but that's something else to think of, how you can have a steady stream of blood pressure cuffs flowing to your health centers of validated blood pressure cuffs. So with that, I think that is the end of my presentation, and I'm open to any questions you may have. And thank you again for the opportunity to share some of the work being done at our health centers.
Navia, we really appreciate that very thorough presentation. And, I think to, our audience, one thing that we can look at is, we've discussed that it's not always one size fits all. So, being flexible and, working with the resources that you have, the care team members that you have, and, refining your process over time. Navia and her team have been working on this for quite a while. So, expecting perfection overnight probably isn't going to be the best approach. Right. Navia, we had 2 questions that came in, and Patty, I believe that your question got answered around the data, but Patty wanted to know what you consider vulnerable patients or vulnerable population. What is that a combination of?
So for us here in Hawaii, when we are looking at vulnerable population, we're looking at people below poverty line, number of patients on Medicaid, homeless populations, and then patients with ethnic minorities, plus a mix of everything else that I mentioned, homeless population, and then poverty as well. So, and majority of our patients, like I mentioned, like I shared earlier, do belong to these categories that our health centers serve.
Okay, great. And then a question about billing. SQHCs tend to have a little bit different of a billing mechanism than our fee-for-service partners. So you have a little bit of flexibility with the different models that you can implement. You're not doing like a strict fee-for-service for this work, is that correct?
No, right now, none of our health centers that have an active SMBPM program is billing for SMBPM, because we are looking at SMBPM as remote patient monitoring, and those codes are not active for FQHCs yet.
Okay, great.
So it's coming.
Well, thank you.
Yeah. So we are thinking like it's being covered, they say, under PPS, although we don't agree with that. So we're still trying to get RPM approved for FQHCs.
Okay, great. Yeah, this remote patient work, we're always going to be a little bit a cart before the horse because of the pandemic. It unfortunately launched us into that. So there were no other questions. We want to just thank you for your time and your expertise. And, you know, if any of the audience members come up with any additional questions, if you would be willing to share your contact information, especially for our folks in Hawaii, it sounds like you have some phenomenal partnerships that they may be able to tap into in those communities. That would be great if you could share your email. And thank you so much again.
Thank you. Thank you very much for the opportunity. And please feel free, I put my contact information in the chat. Please feel free to reach out to me or any of my team members at any point in time. Thank you very much.
Great, thank you. And with that, we are going to turn it over to Erin for our discussion questions. There'll be some additional resources in the slide deck that we shoot out to you with the recording that you can review from Target BP. Covered quite a few of those, so we're just going to skip that and launch right into our discussion questions. I'll hand it over to you, Erin.
Great, thanks, Kristen. And thank you, Navia. That was a really great presentation and definitely made me thinking of different ways to work within in the community and working with, you know, local partners and resources for increasing that patient engagement. So let's hear from the folks who are just getting started with SMBP. So have you thought about, or maybe during Navia's presentation, did you maybe think of any strategies that you will use to keep your identified patients engaged? Does anyone kind of want to share what spurred in their mind, like thinking through Navia's presentation, or something maybe you have already been thinking about doing? Is there other strategies that you guys use to increase patient engagement, maybe in any other forms of self-management support, any other programs you may already have running in your clinics? Dr. Humphrey, can you share how you kept your patients engaged in SMBP? Thanks, Kristen, for the question.
Just briefly, you know, one of our, well, we had very good provider support, and with that, see if I can get my video on. But yeah, certainly one of the discussions I had with patients is their experience in the office and getting blood pressures. You know, unlike providers who rely on blood pressures, patients very clearly understand that their blood pressures vary tremendously and the techniques used in doctors' offices vary differently. And in the office blood pressures, I was just collecting my data on office blood pressures. They're very inaccurate. I mean, there's nothing about a blood pressure in the office that really predicts cardiovascular outcomes. And the accumulated data, which leads the American Heart Association to recommend SMBP, is the poor validation of office blood pressures. And I'll share those recent and historic. I was just looking at the Pickering article from 1994, which essentially outlines all the reasons that office blood pressures are not reliable. So we've known this for 30 years, but patients know it absolutely. And many of them have purchased blood pressures and getting blood pressure readings at home and have self-reported those or used somebody else's blood pressure. This is not new to patients at all because the blood pressures have been there. So having an understanding of where the patient is really helps to get the patient to understand that there's a far better way of getting blood pressures. And I think, and then explaining to them that the benefits of that are better management. We can, you know, and generally speaking, a reduction in the amount of medication and a reduction in the amount of visits to the physician. You know, so, you know, if they're interested in their healthcare, there's really only one option, and that's to move blood pressure monitoring out of the office.
Yeah, absolutely. And I think, a testament to what you said, Dr. Humphreys, and Navia's presentation, it's just, I mean, this program can be so beneficial for patients on multiple different levels. So really having that forethought, I think, and that's kind of what I was thinking about during Navia's presentation, is having that forethought around that patient engagement piece and really thinking about your patient populations and how you want to engage with them and what are the best methods.
Yeah, I mean, the resistance to SMBP is not the patient, it is
Yep.
the providers. And if you do not have the provider buy-in, and I've been impressed with other presentations I've worked, that the science behind SMBP is really not shared. And from an academic standpoint and the way I look at things, if you can't prove it to me, I probably am not going to change the way I change my behavior. But continuing to educate your providers on the fact that there's a better way. The resistance really is, as we mentioned last time, the physician national organizations who have failed to endorse SMBP because it's certainly not universal. And I just finished the webinar on HEDIS and NCQA before I got on this one. Continued to rely on the last blood pressure reading of the year and a single blood pressure reading where you can select the lowest one to report for HEDIS metrics. There's nothing about that methodology that has anything to do with patient outcome.
Yep.
And
Yeah,
so we've got huge battles ahead of us.
Yeah, absolutely. And another good perspective, something we talked about last time was, talking with your entire care team, getting everyone on board, talking with your providers, educating staff. All of these things contribute to engaging with patients. So these are just some things to keep in mind, things to generate ideas for your own practice. So Kristen, if we want to maybe move to the next discussion question, and maybe we'll get some folks to come off mute. So our next discussion question is, how do you anticipate your patients will receive education on SMBP? Has anyone thought about that? Like where that will fit in the workflow, staff time, provider engage? Is it, your provider engagement? Who's going to train the patients? How is that handoff going to happen? Where in the workflow is that going to happen? Has anyone kind of had any thoughts around how they're going to integrate the patient education piece into your SMBP program? Does anyone want to share in the chat or come off mute?
Erin, I've seen a couple cool things that I'll share and kind of some efficiencies too. Anything that your care team members are going to repeat a lot, figure out a way to streamline that process. Navia mentioned packets of education with lots of pictures, which is great. She also mentioned group visits. I've seen group visits for diabetes prevention. I've seen group visits for advanced care planning. They were all designed because the care team members were saying the same thing to lots of different patients, and they didn't have the bandwidth to do it. So let's figure out a way to get those patients together in a group and not only build a community, but also make the best use of our care team members' time. So those are just some ideas that I've seen in the field, and would love to hear from folks on the line about really anything that you've got that's kind of worked for how you deliver patient education. This content's of course meant to help you, but we are running out of time. So if you could come off mute, that would be great.
And I'll just add something while we're waiting for anyone to come off mute, interrupt me, or put it in the chat. Navia, you mentioned something that I heard from a clinic. So I'll just speak to them, I guess, in Alaska. We had a clinic in Alaska who's doing SMBP. They said one of the biggest successes that they had was doing education with the patient, going through it, because like Navia said, the instructions on the BP, the blood pressure cuffs, are, could be too advanced for them, too wordy. They're not going to read it. So actually, and I heard pulling the cuffs out of the box, like at least that's what a clinic in Alaska said. They had to pull it out of the box and use it with the client or with the patient, show them at the time of the visit. So Navia, I really appreciate you saying that, kind of modifying that patient education for the patients and not just relying on what comes with the cuffs. Navia, please feel free to add anything that I may have missed.
The other thing our health centers have incorporated is the teach back method. So they teach the patient, and then they ask the patient to teach it back to them as to how are you going to check your blood pressure. So we know if they really understood it, or are they just nodding their head because they want to get out of the visit already. So yeah, they use that as well.
Yeah, absolutely. Ensuring that competency. So I don't know if we have time for that next question. I know we're like running over already. So I'm just going to turn over to Kristen. We're going to talk about those action steps for next time.
Fantastic. All right. So as I mentioned, our last session is getting moved out. So you have a bonus week. So I would recommend not only looking at our call to action items for this session in particular, but going back and looking at all of them from the previous session. So I'll include all of that information, and you as the care team members, in the spirit of learning and peer-to-peer sharing for our final session, I really encourage you to, wherever you're at in your implementation method, pick one area, one call to action items that you're really going to dedicate some time to, and, come prepared with questions for our subject matter expert who is going to talk about full implementation. We're also going to talk about some quality improvement initiatives. Patty is raising her hand and she's hosting that session. So I'm going to turn it over to her to see what she has to say.
Thank you, Kristen. So there's been a little bit of confusion about this last session, and please double check your calendar and verify that you show the last session on July 13th. That's when it is. So make sure that it actually came over for you. If not, please email us and we'll help you out with that. You may have to manually delete the one for the 6th because I don't think that automatically came off. And then the second thing I want to say about that is we have a subject matter expert who's going to be on the phone with us, or on the session with us on that 4th session, for us to just allow for open Q&A for you to ask questions of them. And so we aren't structuring too much of a presentation, but it's going to be more of a open discussion on how we wrap all this up and get you to the next step. So we will cover quality improvement. We will talk about patient data, but it's also an open discussion for you to kind of get the last things you need to put your SMBP in place. So hope everyone can join.
Great. Thank you, Patty. Yeah, I mean, if you've got, questions, you're like, I really need more education, or I haven't quite figured out like how to get provider buy-in. Bring those questions, bring the challenges that you've faced since we started this session. And we'll hopefully get all of those questions answered for you. And then identify some other areas of opportunity if there's some more work that we need to do moving forward. So here is your action item for the week. The one call out is train one patient in SMBP. This can be a test patient. If you have a Kristen, train a me, train someone on your care team. Get experience in working through what this actually is going to look like when you have a patient. So think about that. And then, if you want to if you are to the point where you're identifying how you're collecting data and how you're going to monitor your effectiveness, get there. But if you're still working on some of those beginning and foundational steps, that's totally fine. This is, as we said, baby steps to greatness. You have to start small in order to, get something of this magnitude up and off the ground. So, keep up the good work. Thank you for your continued participation and your attendance. We're always thrilled to have you. Thank you so much for all of our subject matter expertise and all of our regional partners that make this available. And we look forward to talking with you in a couple of weeks. Have a great holiday. And yeah, if you've got any questions or any technical difficulties with that last session, reach out to us. We're here to help. So thank you so much and have a great day, everyone. Thank you.
Thank you.